Good morning, guys. I hope we're all sparkly. As you can tell, it's morning time. The birds are singing. I thought I'd do a quick update on subcutaneous testosterone injections. As you know, I am a massive advocate of daily subcutaneous testosterone Cypionate and HCG injections. Why? To hopefully mimic natural physiology, which should be the reason or the premise behind TRT. Understanding that we should be working with your body, not fighting against it. The temptation is to think, oh, I'll just bang in a little bit more to make me feel even better, but not realizing in order to establish balance, the body has contrasting physiological processes and mechanisms in order for that to be applicable. Catabolic, anabolic, sympathetic, parasympathetic. It's true of many things in life. In order to establish balance and harmony, you need contrast. You heard it here first. So the temptation might be to have a little bit more to make you feel but in order to feel balanced and normal, remember normal is actually pretty bloody good. You're designed to fight and fornicate. So why do you want to be anything other than you actually are? Now we have a deficiency, let's correct the deficiency. That makes sense. Maintain function and correct the deficiency. So subcutaneous injections. I've already done a video on this, comparing it with intramuscular injections, but I'll do a quick update. Sub-Q is less painful, there's less risk of scar tissue development, and there's less risk of aromatization or excess aromatization of testosterone to estrogen. Now the testosterone will be aromatized to estrogen because it obviously will be exposed to the aromatase enzyme once it's arrived at the liver, but that mechanism is slower because obviously in subcutaneous tissue it needs to go into the capillaries and or the lymphatic system that drains into the venous system, and then it goes to the liver to be cleaved. So that process is slower. So subcutaneous gives a more natural testosterone to estrogen ratio because it slows the conversion, because you're not insulting the liver straight away with a big load of testosterone attached to the ester that then gets cleaved. Make sense? I hope that makes sense. So subcutaneous injections, gold standard, baby. Does it suit everybody? Does it suit every ester? The answer to that question is no, obviously. Medicine is a practice, and you have to work with the tools that you have in front of you. Now here at the Men's Health Clinic, our preferred ester is Cypionate for the reasons discussed. The carrier oil is olive oil, so it's not very irritant. And the preservative is benzoyl alcohol, and that's only a very small concentration compared to that horrible substance Testosterone. So Cypionate is very well tolerated. Is it tolerated by everybody? No. I have had one guy that said he has had irritation from subcutaneous testosterone Cypionate injections, and so we've switched him over to shallow IM and problem solved. You cannot have a one-size-fits-all methodology, and you cannot promote dogma because it shows you're an idiot. Never do this, always do this. Just shows that you have no appreciation or understanding of medicine. So, what other esters can you use sub-Q? Well, you can use enanthate. We did use enanthate, and I do have a few remaining guys on enanthate, but it does tend to cause lumps, partly due to the fact the carrot oil is viscous, so it's sesame oil compared to olive oil, and the preservative is chlorobutanol, and it's in actually quite a high concentration that is known to be irritant. So we have found that, and we did have a few issues. The research, so again, if you just go on the research and go, I'm going to follow the research, and until the research says otherwise, until I have an interventional study, I am not going to change my practice. Well, again, that demonstrates a short-sightedness and ignorance, because enanthate is deemed to be safe and effective subcutaneous via the subcutaneous injection route. However, we found in a large number of guys that it did cause lumps, some of them painful, and the occasional cellulitis, and hence we changed to Cypionate, and we follow our guys up carefully and closely to make sure that safe and effective practice is at the paramount and the core of everything that we do. Enanthate. I do have guys on enanthate because they are under the care of the NHS, meaning the NHS has kindly agreed to prescribe enanthate, which makes it a bit cheaper for some of my guys. But it isn't the best ester. Cypionate is the best ester. And a lot of the guys that are still on enanthate, I've actually changed them over to shallow IM. And we don't normally do the dailies, we do sometimes, but we have to sort of balance the risk of stable levels versus comfort, and pinning every day, even if it's via the shallow IM with a 27-29 gauge insulin needle, can be a bit of a pain, no pun intended. But most of my guys on enanthate are now on shallow intramuscular injections because of the potential for irritation. And interestingly enough, enanthate is 250 milligrams in a mil. The concentration appears to influence the absorption. So if you inject the same amount in the subcutaneous tissue of enanthate than you do Cypionate, which is a weaker or a less concentrated ester, 250 milligrams in 2 mils, what we tend to find is the numbers are lower with enanthate than they are with Cypionate. So if you switch somebody over from enanthate to Cypionate subcutaneously, then your numbers are likely to increase, and conversely, if you switch over from Cypionate to enanthate, numbers tend to decrease. There's also another interesting point. When you switch over from shallow intramuscular to subcutaneous injections, you often feel a dip. So do not expect to feel amazing straight away. It's not like starting again, but it's not that far off. So you do have a slight dip as the route of administration either reaches saturation. It's interesting. I don't fully understand the mechanism, but you do have a slight dip as the oil has to go via the capillaries and lymphatic system into the venous system and then to the liver. So don't be disheartened if the first week, 2 weeks, you do feel a slight drop. It does come back up, and the long-term benefits of subcutaneous injections, in my mind, outweigh the risks of shallow intramuscular injections. Esters that are not appropriate for subcutaneous injections: Testosterone, that has a very high benzoyl alcohol content and will be irritative. It's already known to cause post-injection pain if you inject it into the intramuscular region. So inject it subcutaneously and you're almost guaranteed irritation and pain. Does it apply to everybody? No. But as a clinician, I would not advise injecting Sustanon via the subcutaneous route for that reason. Libido, oh, bloody hell, could you imagine? They did do some research, and there's a paper, so you can apply this standard. You can inject libido subcutaneously. It's got castor oil in it. It's incredibly viscous, but the research says so you should do it. No, you should use common sense and experience, not just rely on research. Well, the data says, yeah, the data might say it, but actually in practice, it's not possible, or it's not sensible. Could you imagine? I mean, they must microdose it, but I mean, libido is a shocking substance. 4 mils, 1,000 milligrams every 12 weeks. In whose mind did that make sense? As you guys know, I have a couple of patients on libido. One injects weekly, one injects every 2 weeks, so 125 and 250 respectively, and they get on really well with it. The downside obviously is you can't titrate the dose. That's your dose. When you understand the need for personalized medicine in especially hormone replacement therapy, that isn't always wonderful. So that both of those guys are actually on HCG. So the titration is with the HCG, not the testosterone. So the testosterone acts as a base, and I titrate with the HCG, which is converse to traditional TRT, which is providing a base with HRT and maintaining function and topping up with testosterone. That's not everybody, that's just my gold standard, but doesn't apply to everybody. I've got lots of guys just on testosterone monotherapy, guys on testosterone and Proviron, who have got low DHT, and I've got guys on Proviron on their own who have had massively high SHPGs without a reversible cause, and Proviron has been effective. Whether that will be true long term, only time will tell. But at the Men's Health Clinic, we actually follow people up and we look after them. So we will review as necessary to make sure we continue safe and effective care. So subcutaneous injections, it's the way forwards. Microdosing, using the minimum effective dose to achieve the desired outcome. Balance, baby.